My main objectives are to explain just how syndesmotic injury is such a scourge for ankle health, to discuss evolving themes in our understanding of how to actually characterize the alignment of the ankle syndesmosis, and then some of the evolving surgical techniques that have come to the fore as we're trying to figure out how to evolve beyond just screw fixation. A certain section of that, an important section on ankle deltoid ligament, will be handled by Dr. Preisel. The ankle syndesmosis provides stability to the ankle joint and flexibility at the same time. Its principal function is to resist rotational forces, which would otherwise, and in some cases, be injurious. Our goal as a surgeon is to restore the stability of the ankle joint, and oftentimes this involves anatomically realigning and repairing the ankle syndesmosis so that with proper healing and rehabilitation, the person can regain the same function they had pre-injury. Is it that important? Yes, it absolutely is. Our historical literature tells us that ankle joint malalignment changes contact area, and this changes the forces. So ostensibly, this would be the mechanism of ankle arthritis in the unstable or malaligned ankle. Most recently, the ankle syndesmosis' role in ankle health became much more apparent, especially in response to studies like that of Dr. Hunt, who demonstrated impaired contact stresses and altered mechanics of the ankle with syndesmotic injury. This year, we learned that malreduction or fixation in malreduction actually contributes to residual instability beyond just the initial injury. In this very well done study, they fixated intentionally syndesmoses and malreduction and demonstrated rotational instability was actually worse with malreduction. And that occurred in both the posterior and anterior direction. So malreduction we already knew mattered clinically because there have been studies demonstrating poor outcomes among those with syndesmosis malreduction. So some of the evolving concepts, particularly with regard to last year's literature, are how do we actually assess ankle syndesmosis alignment and some of the more advanced techniques for restoring alignment and mechanics. Now, the rate of malreduction varies quite widely depending on what the intraoperative modality was for assessing the syndesmosis and what study you're looking at. And if you take them all together, clearly there's just a lot of variation or heterogeneity in the populations under study, particularly with regard to the pattern of injury, the methods of treating it, the definitions as to what is aligned and non-aligned, especially magnitudes of these values that we quote to each other, and who observed it and how they made those observations. But everyone is trying to get it right the first time, to assess a reduction, obtain a reduction, and maintain it. And that would seem easy. It's not. In 2013, we were advised to start working off of a contralateral lateral view. In this case, we would use a roughly symmetrically aligned and magnified view of the contralateral healthy ankle as our model for obtaining and maintaining the reduction ipsilaterally. Although we actually never had any validation that this is truly the best way to go. Well, last year I read with great interest that the fibula does actually align in roughly the same place on both sides, and that when you subject it to very careful measurement, that the differences are rather de minimis. In this study, looking at almost 250 ankles, they could really find no substantial or statistically significant difference in the position of the fibula in a weight-bearing x-ray, and therefore the contralateral x-ray does serve as a valid template. But there's a couple of catches that we should be aware of. In this study with Koenig and Tornetta, 4 experienced traumatologists actually had difficulty necessarily using a healthy contralateral x-ray to assess ipsilateral malreduction, particularly in small magnitudes, so that would be 2.5 millimeters, or in anterior direction, whether 2.5 or 5 millimeters. But what they did best was assessing a large magnitude of posterior displacement, which would be 5 millimeters. And in this case, these boxes, by virtue of their color, let you know roughly how well they did in each of these categories. So human error is a factor. Another is that fibula rotation can be clandestine. If you malrotate the fibula up to 30 degrees externally, you may still end up with relatively normal, if not completely normal, coronal and sagittal plane X-ray radiographic parameters. And so you have to pay very careful attention to the alignment of the fibula. Also, and this is not surprising, The alignment of the limb itself in three-dimensional space matters substantially to the values that you would obtain in the traditional measurements, such as tib-fib clear space overlap or medial clear space. And the same applies on the lateral view. In some of these studies, the results are so incontrovertible that this has spurred us to look for better ways of putting it all together. So theoretically, in a perfect world, we would all have intraoperative CT, right? Well, they had that in New York and compared the outcomes of two centers, and Davidovich reported that the center with intraoperative CT actually had a higher rate of postoperative malreduction when you got CT of all these ankles. Also, in Europe, Franke demonstrated that they couldn't use intraoperative CT necessarily as a factor to predict less malreduction. In fact, the pattern of injury and other factors didn't predict who would have postoperative malreduction. So what about the new, more weight-bearing or cone beam CT options? In this study, they were able to bring it into the operating room and allow the surgeon, who was blinded to what they were actually assessing, to use it to assess their own syndesmosis alignment when they went through fixation. And in this case, approximately half of the time, the surgeon still opted for a less than ideal postoperative reduction. In terms of clinical outcomes, this correlated to poor outcomes among those with the less optimal alignment. And the authors argued that theoretically, if you gave the surgeon an accurate target, they could hit it 100% of the time, provided that they had this imaging modality. Well, that may not actually be true because 89% of us have an asymmetrical anatomy to our ankle syndesmosis. In fact, if you use the most commonly described Gardner protocol of anterior-posterior tib-fib clear space distance, 35% of us already are categorized as malreduction before we get hurt or have surgery. And so there's a high rate of false positivity. And this also calls into question how accurate we can look at the results of studies in which a bilateral CT protocol was applied. It probably also explains the rate at which those who do use these clinically find that the call from the radiologist is that you still malreduced your ankle syndesmosis. Saji proposed backing all of this indirect and fluoroscopic views up with a direct open approach, and demonstrated in their category that they were able to drop their malreduction rate by about threefold. Well, the problem is that there isn't a really standardized open reduction method that's been subjected to scientific study. And most of this is just a gestalt of looking either directly at the anterior ankle syndesmosis, in which you can assess the fibula and the tibia, or still a relatively indirect posterior syndesmosis assessment in which you can largely palpate the alignment of the two. So some fair summations that I would propose with regard to assessing syndesmosis are that the attention to detail is key, that comparison images are truly helpful, and standardizing them as much as possible is critical. Using multiple planes and multiple parameters is better than not. Open assessment is a good method, especially if you have the opportunity to do so. Cross-sectional imaging in the OR would be nice if we could all have it, and you have to be careful about your own post-operative CTs because you may get called for malreduction when in fact it's probably just fine. So evolving fixation concepts is also a very interesting area of growth, especially in the last year's worth of literature. And what we'll find is several principles, such as the importance of the fixation axis, that flexible fixation is here to stay, and now we're actually just starting to figure out how to optimize use of it, that the repair of the deltoid is emerging, and I'll entirely defer on that to Dr. Preisel, that the posterior malleolus can and should be repaired if you need it to, and anatomic syndesmotic repairs, such as ligaments, is very valid. The fixation axis problem is actually very well described, and if you look, there's a large number of cadaveric studies demonstrating that fixation axis out of plane from a theoretical neutral axis, which has not yet been defined, does contribute to displacement of the fibula in multiple planes, usually rotation and displacement at the same time. And it's pretty important also to consider that the anatomy of the incisura may be impacting the direction that the displacement occurs. In this study, where they looked at the actual morphology, a deep incisura was more likely to encounter overcompression when the surgeon performed fixation, or those with a more shallow anterior margin became anteriorly translated, and the same for a more shallow posterior margin with posterior translation. the axis of fixation and how to localize it is also evolving. The most traditional technique is to simply drop your hands roughly 30 degrees and to try to shoot between the center of the fibula and the tibia. But newer techniques now are trying to methodologically target a more consistent product and therefore find a more consistent alignment. Two relatively promising techniques are the transsyndesmotic angle and the center-center method. The transsyndesmotic angle is rationalized based on bisecting the incisura and then aligning fixation between the fibula and the tibia along this bisecting alignment. And Cosgrove and colleagues, as well as Putnam and colleagues, demonstrated that this is roughly 21 degrees, but plus or minus 5 degrees off of the true lateral view of the ankle. And the clinical lesson that they proposed is that when you're looking at a true lateral view of the ankle, you would want your tines to compress the tibia and fibula together with the medial tine in the anterior third of the tibia. And that's what's depicted in the center picture here. Cancian and Yarbrough proposed a more patient-specific alignment by using the internal rotated lateral view to align the centroids of the fibula and the tibia, and proposed that by using a relatively familiar perfect circle style technique such as used for intramedullary fixation, you could also achieve syndesmosis fixation along a neutral patient-specific axis that does not cause displacement. But they didn't validate this or provide any clinical outcomes, so we picked up on that work and we used cross-sectional imaging to simulate both a centroid and center-center axis. And what we found was that at 10, 20, and 30 millimeters above the ankle plafond, that the difference between these two axes was relatively de minimis, less than a degree, almost in all specimens. And so what we concluded is that the center-center methodology does provide a centroidal axis of fixation. Now, the flexible fixation versus screw debate remains to some degree, but it has evolved to the point where syndesmosis fixation using flexible fixation is here to stay. In a relatively landmark prospective study, Corticangas demonstrated roughly similar outcomes or more non-inferiority between the two fixation constructs. And similarly, Cocaidal did as well. But with this year, I read with great interest a 5-year outcome study of a randomized controlled trial in which there was actually slightly better outcomes with the flexible fixation. Now, studies like this can really drive practice. So what I'm going to point out here are several important caveats. And the first is that the AOFAS ankle hindfoot score has been relatively widely accepted as being invalid, and the outcomes are not very useful, particularly with judging the outcomes of this study. For the Olerud-Melander score, in which it was actually better in the flexible fixation group, the 95% confidence intervals overlapped. So the clinical difference may not have matched the statistically significant difference. And it's important to note that radiographic ankle osteoarthritis is not necessarily clinically symptomatic. And although in this study there was a higher rate of symptomatic or a higher rate of radiographic arthritis, it wasn't necessarily clinically symptomatic. So this doesn't necessarily, hands down, prove that flexible fixation is better. Anatomical approaches are and will continue to get more attention, particularly as we realize what is possible. So for example, Little reported that they had a lower rate of ankle syndesmosis by anatomically addressing all that there was to address, whether it was to directly repair a ligament or to directly repair a fracture that afflicted the incisura. And we do know that it is important, and I am quoting back to Dr. Hunt's study, that displacement of the ankle is driven to some degree by syndesmotic instability to support the fact that ligament reconstruction is, and where possible, a valid reconstructive technique, at least biomechanically. In this study, repair of the ligaments was equivalent but not better than screws in restoring the syndesmotic stability in rotational malalignment or rotational displacement. Also, Gardner demonstrated that repairing, where possible, posterior malleolus fractures can also restore rotational stability, perhaps even better than screws in the setting of ankle fracture with a large posterior malleolus fracture. It's also not necessarily been demonstrated that screws are better than anatomic repair with regard to augmenting the anatomic repair. So in this study, the authors used a suture tape to augment an anterior syndesmosis ligament repair and compared that to screws alone. But what they weren't able to demonstrate was that it was actually superior, although it is a compelling thought. And I think we're going to see more studies on this, probably ones that show better outcomes. A partner of mine, Dr. Hagen, recently reported the rotational restoration that allograft ligament reconstruction of the syndesmosis can have. Now, this technique seemed to emerge 12 or so years ago, and seems to have gone back down for a while, and it's coming back up. I think this year we'll see more than one study come out like this. This group out of Seattle actually did reconstruction of two methods, one using Achilles tendon allograft and one using a transfer of a peroneus longus tendon. And in their biomechanical test, they were able to demonstrate restoration of intact equivalent rotational stability. And so it would seem that even in late reconstructive phase of care, it's possible that allograft reconstruction might be a strategy that we can employ. And of course, one of the most quoted studies in this regard is a relatively old study by Bumer, in which they recommended a pedicle advancement for the AITFL origin off of the tibia, augmented with transsyndesmotic suture screw fixation, and demonstrated that this restored rotational alignment substantially better than just the screw alone. Of course, following up with clinical outcomes in this area is hard, and so we have two small samples of a case series of patients with clinical improvements, but not necessarily anything that is a high level of scientific evidence.